I'm going to share my screen. Okay, can you see it in the right mode?
Yep, looks great.
Okay. Well, first of all, thank you so much for inviting me. I mean, I have to say I'm quite intimidated to be talking to like super smart critical care doctors. And I see John Arpella there. Like when I was a fellow rotating through this, the surgical ICU, he was my attending. So completely intimidated. So I hope this is not too much beneath your level, but hopefully we'll get some points in there. So thank you again. It's really an honor. I don't have any disclosures. Okay, so I'm just learning objectives, just to learn the physiologic changes that occur during pregnancy. I think it's really important that we consider the cardiac as well as respiratory changes because it impacts our sort of resuscitation maneuvers in cardiac arrest. Understand the approach to managing the pregnant patient who has a sudden cardiac arrest. Learning the difference in management of the pregnant patient versus sort of the non-pregnant patient, and understand the rationale for conducting perimortem cesarean delivery. I think this is sort of a timely topic given our recent cardiac arrest that we had on the labor force. So, I'm glad to have. I went through so many iterations, like what am I going to talk to you all about? And like aortopathies, and I came up with all these different things, but I think this is timely. All right, so I just want to go through some background maternal physiologic changes that occur during pregnancy that are relevant. So major adaptations in maternal anatomy, physiology, and metabolism occur throughout pregnancy, starting really quite early on. Every organ system is affected. And mainly these changes are for the benefit of the fetus. There are some that are advantageous for the mom too, but mainly for the fetus. And then things tend to return to the pre-pregnancy state by about 6 weeks postpartum. So it's, all the changes, it's really about the hormones. So estrogen is produced mainly in the placenta, there are maternal and fetal precursors that occur in the formation of the different types of estrogen, and then progesterone as well is really impactful in terms of the physiologic changes. There's complex synthesis that occurs in the mother, the fetus, and the placenta, and it does start with maternal cholesterol as a precursor. So starting with estrogen, estrogen increases the synthesis of procoagulant factors. It increases liver synthesis of fibrinogen, ceruloplasmin, transferrin, and binding proteins for corticosteroids, sex steroids, and thyroid hormones. Can induce a mild cholestasis picture. It is what's responsible for some of the ligament laxity that occurs. It is what is related to the increase in diabetogenic state, and stimulates the growth of the breast ducts as well. As far as progesterone early on in pregnancy is very important in maintaining the pregnancy until the placenta takes over the production of progesterone. It's mainly beginning from the ovaries. It conserves potassium. It's involved with smooth muscle relaxation. So smooth muscle in the blood vessels, the ureters, the uterus, and the intestines. It is what is thought to be responsible for the hyperventilation that we see during pregnancy, as well as the respiratory alkalosis from the hyperventilation. And it also contributes to hyperglycemia and insulin resistance. So in terms of the cardiovascular system, the heart is really displaced due to the elevation of the diaphragm and tends to be displaced superiorly into the left. And on chest x-ray, it can appear quite enlarged. Cardiac output is increased by 30 to 50% during singleton pregnancy, and as high as about 70% in twins and 80% in triplets. So not only do you have to keep in mind that increase in cardiac output, but you have to think about it in terms of whether there's a multiple gestation involved. So anatomically, the entire chest cage changes. So not only do you have elevation of the diaphragm, but you also have widening of the chest as well to about 2 to 3 centimeters, which is really why a lot of pregnant patients complain of rib pain. But as far as the heart itself is concerned, the ventricular mass increases, the end diastolic volume increases due to the increased cardiac compliance from the effects of the relaxation of the muscle from the estrogen and progesterone, as we just talked about. And this allows the heart to accommodate the increase in volume. Turns out there's no change in end systolic volume or end diastolic pressure, which is also advantageous for the mom. So some of the normal signs and symptoms that pregnant patients complain of can be quite normal, and some are not. So sometimes it's really tough to tease out what is normal and what is not. And this is often done by physical exam, history, etc. So very normal that pregnant patients complain of dyspnea, fatigue, syncope, chest discomfort, edema, and systolic ejection murmurs. So trying to sort out, is this normal pregnancy or is this indicative of some underlying condition is sometimes challenging. So in the non-pregnant state, when we talk about cardiac output to the uterus, it's about 2 to 3% of the cardiac output. However, by term, it's about 20%. So there's about 500 to 800 milliliters per minute of blood flow to the uterus. Kidneys, it increases up to 50%. And the pregnant uterus can decrease the preload by compression of the inferior vena cava. So if you look at this graph here, this shows the increase in the plasma volume. And you can see at the very top, let me start from the bottom, increase in the red blood cell volume, increase in the plasma volume, and the total blood volume. This begins as early as 6 weeks in gestation. It peaks around 32 weeks, reaching about 4,700 to 5,200 milliliters. And again, red blood cell mass increases as well, but not as much as the plasma volume, which is why delusional anemia is a fairly common finding in pregnancy. So I know I don't have to remind you of the equation for cardiac output, but I always have to remind myself. All stroke volume and heart rate all increase in pregnancy, leading to an increase in the cardiac output. The stroke volume tends to start to decrease near term, and the cardiac output is dependent on maternal position. So it's lowest in the sitting or supine position, and the uterine pressure on the IVC really can change that cardiac output. The heart rate tends to increase by about 15 to 20 beats per minute from 5 weeks up until 32 weeks. And the stroke volume, again, increases up to 20 to 30%, peaking at around 20 weeks of gestation. In terms of systemic vascular resistance, it decreases by about 5 weeks, and this is really due to the effect of progesterone mainly, but prostaglandins and relaxin also play a role. There's an increase in venous compliance and low resistance of the placental circuit. Part of the decrease of systemic vascular resistance is the low resistance in the placenta. Interestingly, the placental vessels can autoregulate, so there's no obstruction to maternal delivery of nutrients to the fetus. And as I mentioned, so many of these changes are to the benefit of the fetus. Blood pressure, arterial blood pressure decreases by about 7 weeks. There's a decrease in peripheral vascular resistance. And there's also circadian rhythm of blood pressure. So it naters early in the morning and peaks later in the afternoon and evening. It's the left lateral recumbent position will lead to a decrease both in systolic blood pressure and diastolic blood pressure by anywhere from 5 to 10 millimeters of mercury to 10 to 20 millimeters of mercury. So typically we do try to take the blood pressure in the sitting position just to so that we're not falsely lowering that blood pressure when we're evaluating patients for preeclampsia, for example. So just to sort of put it on a graphic, looking at all the different changes that can occur, you see, what is increased during pregnancy, as I mentioned, cardiac output, heart rate. The systemic vascular resistance should be decreased there, as well as peripheral vascular resistance. No change in the CVP or pulmonary capillary wedge pressure. So that's just a summary of all the changes that occur. In terms of the intrapartum changes, in the first stage of labor, which is getting up to full dilatation, the cardiac output increases by 12 to 31%. Stroke volume increases about 22%. And in the second stage, when somebody's pushing, the cardiac output increases to about 50%. With contractions, there's 300 to 500 milliliters of blood transferred to the maternal circulation. And the systolic and diastolic blood pressure also increased during the second stage. The transfusion of blood from the uterus at 300 to 500 during contractions, is usually well tolerated if the mom has good heart, but if the patient has underlying cardiac disease, it can be problematic. In terms of postpartum, the cardiac output increases by about 80%, and this is due to release of the IVC obstruction from the delivery of the fetus. There's autotransfusion of the uteral placental blood and mobilizes third space. And this is why often, unrecognized mitral stenosis is diagnosed in the sort of immediate postpartum period up till 24 hours, because what was previously tolerated, all of a sudden there's this huge increase in cardiac output, and then we see the effects of pulmonary edema and impact on the heart for these patients. So I just have one slide, just going over the respiratory changes, because again, it does impact on the resuscitation maneuvers. So as the pregnancy advances, there are anatomic changes to accommodate the enlarging uterus. The rib cage, as I mentioned, enlarges, the lung volumes are reduced. As you head towards the third trimester, the functional residual capacity and the end reserve volume and residual volume are decreased. Due to the effect of progesterone, there's an increase in minute ventilation with no change in respiratory rate. And we don't see any changes, in the diffusing capacity of the lung for carbon monoxide. So no changes really physiologically in the AA gradient. The vital capacity and the total lung capacity are almost always unchanged or might be slightly decreased. In terms of the changes that are related to the airway, the pregnancy weight gain and increased breast size can make optimal head and neck positioning quite difficult and decrease the space available to open the mandible and place the laryngoscope blade. The use of a short laryngoscope handle might be helpful in these cases, and also the need to maintain a tilted body position for left uterine displacement can also impede the optimal positioning for airway management. The edema that often occurs in pregnancy, especially towards the end, can also reduce the oropharyngeal diameter, again, making intubation more difficult. So on to the main topic about cardiac arrest. Hopefully understanding those changes will help understand the challenges when arrest occurs. So just we'll go through a little bit of background, risk factors and etiologies, and then talk about some treatment algorithms, including pregnancy-specific interventions or considerations, as well as perimortem cesarean delivery. So maternal cardiac arrest is becoming a more common and is a potentially morbid obstetric emergency. Treatment algorithms are modified based on both pregnancy and gestational age, and early consideration of how to effect a cesarean delivery is an important step to optimizing outcomes. The treatment algorithms are different from outside of pregnancy, and in case I don't know how often you have to redo your ACLS training, but they were modified, I think, in 2015. So the incidence, as I mentioned, of maternal cardiac arrest is increasing. The occurrence is about 1 in 20,000 to 1 in 50,000 deliveries. So since it's so rare, few providers are really comfortable with this because they just don't have the routine, volume to undergo with such, cardiac arrest treatment and practice with this. If you take a standard ACLS class, there's often little time dedicated to pregnancy, but if you look at the materials, then you can really find the information on changes in pregnancy. As I mentioned, the cardiac arrest is increasing, as are other severe maternal morbidity mortality measures. Unfortunately, all these numbers are going up. Data from this study looked at data from 2 points in time and included over 49 million deliveries. And they found cardiac arrest during pregnancy or postpartum went up by about 245%. So really the question is, why is it increasing? And there have been many things that have been put out there to suggest why. Some thoughts are that women are getting pregnant at an older age. The incidence of hypertension is increasing, as well as the incidence of obesity. And also patients who've had, born with severe congenital heart disease are surviving to get pregnant, and they're as they're getting older and getting pregnant with these underlying conditions. Here we have a maternal congenital heart disease clinic that we follow patients along with the cardiologists. So in terms of risk factors and etiologies for maternal cardiac arrest, some of the most common is pulmonary embolus. This data comes from a review from the United States and the UK. About 30% hemorrhage, about 17% sepsis you see, and then lower preeclampsia, eclampsia, and complications related to it, to anesthesia. This slide is quite busy, but I think again it highlights, the issues with postpartum hemorrhage, heart failure, being sort of more common. Amniotic fluid embolism is there, of course, as well as sepsis. And then if you look sort of at the far right, the survival to hospital discharge varies a lot. It generally tends to be in the range of somewhere between 50 to 80%, although for certain conditions it's quite low. So for example, if you look at trauma, it's only 23%. So really the outcomes are somewhat dependent on the etiology that for the cardiac arrest. So it's important for me as a maternal fetal medicine specialist to identify high-risk women, and then to involve subspecialists who can help lead multidisciplinary care approach to the care of these patients. So preconception early pregnancy, look for an increased risk for cardiac complications, a careful H&P to identify signs or symptoms of heart disease, and medical disorders that affect cardiac function are really important. Getting a history, personal history, family history of congenital or acquired cardiovascular disease, including history of arrhythmias, systemic pulmonary ventricular dysfunction, or prolonged QRS, hypertension, cigarette smoking, obesity, diabetes, or family history of premature coronary artery disease or an MI is important to elicit. And then later in pregnancy, some of the things that we think about, we can't really, very, very hard to predict who's going to have an AFE. It just tends to be a catastrophic effect. But cardiomyopathy might be something that is a little bit more predictable based on history. And then other risk factors are postpartum hemorrhage and preeclampsia with severe features. So In terms of prevention, obviously a patient with known maternal heart disease needs to be followed by maternal fetal medicine specialist and cardiology and take a multidisciplinary approach to the management. It's not uncommon that we have interdisciplinary meetings where we involve the critical care team if we're anticipating admission to like a CCU that will be needed. We talk about certainly the risk of hemorrhage, aggressive treatment of conditions that might deteriorate, so hypertension, and again, hemorrhage with blood product replacement. And really important to keep in mind a very low threshold for admission to the hospital. And this is really because the survival is best when the cardiac arrest occurs in the hospital as compared to outside of the hospital. So if there's any question about, symptomatology, it's better to admit the patient and work her up. So let's move on to treatment algorithms and pregnancy-specific interventions or considerations to think about. So we'll talk about pregnancy-related modifications to cardiac resuscitation. So number one is prep for the OB and PED support, because some of these patients will come through the ED and may require delivery within 5 minutes, and I'll get a little bit more into that 5-minute time period. It's not an easy thing to do, especially in the middle of a chaotic situation. Number two is the need to do slightly different maternal maneuvers. Interestingly, it used to be thought that the location of where you're going to put your hands to do chest compressions was different in the pregnant patient, but now the recommendations have changed and are the same for non-pregnant individuals. So if you haven't reviewed this in the last few years in the ACLS guidelines, it's worthwhile to look at that. You also want to make sure you perform left uterine displacement, because especially as you get further along and you have aortic cable compression and decreased blood return during the code, it can be done in a few ways, and I'm going to show you some images and pictures of how it can be done. You and your OB/MFM counterpart need to focus not on the fetal heart rate during resuscitation, and we do recommend removal of fetal monitors prior to defibrillation if that is what is needed. As far as the airway, there needs to be early consideration for airway intubation. Interestingly, again, older teaching was there was a thought for continuous cricoid pressure just due to maternal physiology, but this has fallen out of favor. It's also been reported that a somewhat smaller ET tube size is needed in pregnancy compared to outside pregnancy. Again, probably related to the airway changes I talked about, the presence of edema, things like that. So in terms of immediate actions, be clear, we need to, and I'm actually not quite sure of this, and we probably should talk about it, is the need to call an OB code, because an OB code needs to go out to many different people, including our neonatal team, of course, depending on the gestational age of the fetus. If it's pre-viable, that's not necessary, but certainly in the realm of viability, it's really important, again, because of the possibility of doing a perimortem cesarean delivery. Of course, beginning BLS, getting the adult code card, use end-tidal carbon dioxide monitoring to determine the presence of return of spontaneous circulation, which reduces interruptions in cardiopulmonary resuscitation by obviating the need for pulse checks. I'm sure all of you know that already. Although the end-tidal CO2 level greater than 10 may correlate with return to spontaneous circulation, it's not really predictive of survival or long-term outcome. We have to think early on about prep for cesarean delivery. This is why often when we have patients who are pregnant in critical care units, we always have delivery trays at the bedside. Assigning a timekeeper to document is always important. Consideration for cardiac massage and cardiopulmonary bypass. And again, the automated external defibrillator should be considered.
Dr. Stone, how do we call for a obstetrics code if we're not in OB, if we're in the ICU or in the ED?
I know, I think it's something that we have to work on, because I know in this case, when they called a code, it was like they had to give a lot of really information, and I don't think we have a special OB code. And it's something I think we need to work on. When I was putting this talk together, I really realized that like there's just a general code, right? And RRT comes down, but nothing really specific for OB code, where the neonatal team is going to come as well as the RRT and critical care. So I think it's something that, a good takeaway point from this is some way of improving that, so we have a specific code. So happy to work with you on that. Just volunteered you and me.
Thank you.
Yeah. And then always thinking about treating underlying causes. So some of the factors that may cause or contribute to cardiac arrest should be treated. So DIC or bleeding, certainly. Correction of any electrolyte abnormalities, tamponade, treating hypothermia, hypovolemia, hypoxia, hypermagnesemia can be seen, an MI, porous. If there's poisoning, an embolic phenomenon like pulmonary embolism, certainly anaphylaxis. If there's a tension pneumothorax or aortic dissection. Aortic dissection has one of the worst prognoses, really, for survival. So when evaluating and treating the possible causes of arrest, there are some causes that are unique to pregnancy. So anesthetic complications. So thinking about, did she just recently get a spinal or an epidural anesthesia? Bleeding from like uterine atony, placental abruption, or placenta previa, underlying cardiac disease, what drugs have recently been given. Thinking again about an embolic event like a pulmonary embolism or amniotic fluid embolism. Treating sepsis, and then non-obstructive causes of cardiac arrest should be considered, and then hypertensive disorders of pregnancy like preeclampsia or eclampsia. So in terms of treatment algorithms, I know you guys are all aware of this, but just review. It used to be ABCs, now circulation is first. You know this better than I do, but it's really important also to add to this in pregnancy, the extraction of the fetus as part of the treatment algorithm. So in terms of circulation, left uterine displacement is really important to get as much blood back to the heart as possible. Doing chest compressions at least 100 per minute, and getting IV access above the diaphragm. Always important to not interrupt chest compressions during the resuscitation. So if you look here, the used to be getting a board to sort of tilt a patient had been what was used. Now it's considered manual displacement, and this is some pictures of how you can manually displace the uterus is recommended. It's much easier to do than getting the board, and it seems to work better. Increased risk of hypoxemia due to decreased functional residual capacity and increased O2 consumption and increased intrapulmonary shunting occurs. Bag mass ventilation, 8 to 10 breaths per minute with 100% O2 and suctioning the airway. Again, using a smaller endotracheal tube and intubation when needed. Again, the use of cricoid pressure is now controversial. The supraglottic airway devices should be considered when you're unable to intubate. And a large uterus with an elevated diaphragm really does increase resistance to ventilation. In these patients, lower ventilation volumes like 350 to 500 millimeters are used compared with the non-pregnant patients of 600 milliliters. Ventilation during cardiopulmonary resuscitation should allow the chest to rise but not cause overinflation, which will further decrease thoracic compliance and increase intrathoracic pressure, impeding venous return to the heart. Hyperventilation does have adverse effects and should try to be avoided in any patient undergoing resuscitation. In pregnancy, the non-physiologic respiratory alkalosis, normally pregnancy is associated with a mild respiratory alkalosis, can cause uterine vasoconstriction that can lead to worsening fetal hypoxia and acidosis. So with regard to chest compressions, I mentioned before that it was previously recommended that the hand placement was higher than in non-pregnant patients. However, the newer guidelines that came out in 2015 suggest that hand placement should be exactly the same as in the non-pregnant patient. In terms of the process, so again, ventilate with 100% O2, don't interrupt chest compressions, the jaw thrust and chin lift, bag mask. Again, you can see the cycles of 80 to 100 chest compressions for 2 breaths. Always think about positioning of the patient, consider the optimal position, again, smaller AT tube. Again, primary temp can be used, but you can think of direct or video laryngoscopy. Second attempt, you might want to again try I can't pronounce that word, laryngoscopic technique. Return to mask ventilation if you need to, and then think about alternative airway controls. Airway attempts, though, should not be a long process. So if you have to go back to just bagging the patient, and just do that, because it can't really be a long process. And then the defibrillation is perfectly safe for the fetus. The increase in blood volume and decrease in functional residual capacity does not appear to alter the transthoracic impedance or transmyocardial current. So there's no change in the energy requirements that you typically use. Always important to remove any fetal monitoring before you countershock to prevent electrocution injury to the patient or the rescuers. Fetal monitors also distract from the resuscitation priorities, because the priority is the mom, not the fetus. And when you look at studies of the AHA registry that include 462 in-hospital cardiac arrests, 76% had a non-shockable first documented pulseless rhythm, 24% had a shockable rhythm, 74% had return of spontaneous circulation. In this cohort, the presenting rhythms are suggestive of potentially reversible clinical etiologies such as hemorrhage, hypoxemia, thromboembolism, exposure to toxins, and electrolyte acid-base disturbances. So when we think about postmortem cesarean delivery, because many times it can be related to trauma, you may not know the gestational age, or you're just called into it at the last minute and you have to estimate it. Certainly checking with your OB team and peds whether viability should be considered is incredibly important. The cesarean delivery is recommended if spontaneous circulation is not returned within 4 minutes of maternal cardiorespiratory collapse. So 4 minutes to start to get that process in place. And the goal is to initiate it within 4 minutes and to deliver within 5 minutes after 20 weeks of gestation. If it's somehow appropriate, like patients fully dilated, whatever, you can do a operative vaginal delivery instead of doing the C-section, but that's going to be quite a rare situation. And the rationale behind the number of minutes that are suggested is that irreversible brain damage can occur in the non-pregnant individual after 4 to 6 minutes of anoxia, and pregnant women become anoxic sooner due to decrease in the functional residual capacity. With the uterus above the umbilicus, ineffective resuscitation efforts may become more effective with reduction of aortic cable compression. So by delivering the fetus, you'll have less of that compression. And intact fetal survival diminishes as time for maternal death and delivery increases. So Interestingly, there was a study of 57 cases of maternal cardiac arrest with time from arrest to delivery reported, and only 5 out of the 57 were completed within 5 minutes. So you can see it's really quite challenging. So in practice, 10 minutes is probably more achievable, even though our goal is 5 minutes. 10 minutes is more likely to be the case. So that's why, considering creating emergency cesarean delivery kit for use in the patient's room to decrease delays. Also consider keeping one in the ICU, as I mentioned, if pregnant patients are admitted. We always do try to have a delivery kit in the patient's bedside. And then, we don't really care about a sterile abdominal prep. It doesn't really matter at that point. In terms of where to perform the cesarean delivery, do you do it in the delivery room? Do you move to the OR? Well, it really depends on the institution, how far the OR is. This data that I'll show you here is from a simulation study that randomized to delivering in the DR or the OR for delivery. This was a drill, so of course everything was in place, not like something spontaneous that would occur. That would be quite different. But running drills can help decide what to do. So here they had 15 teams randomized during a drill for perimortem cesarean delivery to delivery in the room or an OR. And there's a significantly shorter time to delivery when it was done in the delivery room than transporting to the OR. And you can see the difference, 4 versus 7 or close to 8 minutes. When delivery was accomplished in the delivery room, the following outcomes were done earlier. So contacting the neonatal team, placement of the defibrillator, resuming compressions, and endotracheal intubation. And it is something that, I think would be great to talk about in terms of running a simulation for cardiac arrest. I know on the west side, they have a really nice sim center, and they ran a simulation for cardiac arrest, but I think it's something that we could talk about doing. I think it's so important, again, given the rarity of this event, but the fact that, it certainly does occur. And again, things like, who do you call? How do you call the code? Who should be coming? Things like that. So just to summarize, and I guess I'm ending a little bit earlier than I thought, but always good to give people time back. So things to avoid, remember, don't focus on the fetal heart rate, the tracing, and certainly if you're in a arrest and the OB is there, like looking at the tracing, just remind them we don't concentrate on that, and remove the monitors during the resuscitation. And don't delay in moving towards a perimortem cesarean delivery where it's indicated. So again, thinking about that 4 to 5 minute timeline should be kept in mind, and that's why having somebody that does record the time of events is super important. In terms of expected outcomes, it really depends on the underlying etiology. The largest study to date reports about a 54% survival to discharge. Neonatal survival was most correlated with in-hospital arrest. Overall survival rate was about 64%. Again, how the infants do also depends on the underlying etiology, as well as, of course, the gestational age. And when the resuscitation is done quickly and appropriately, outcomes are certainly better than what we think. So in terms of the Joint Commission, it's such a rare event that the Joint Commission does recommend practicing emergency drills, and the drills should be used to train staff in the protocols, refine the local protocols, and identify and fix system problems that would prevent optimal care. And again, this is incredibly important as we debrief in the recent case, we'll come up with some corrective action measures that can be used. And I think some of them certainly are protocol-based and system-based that may optimize outcomes. So again, just to summarize, knowledge of the key differences for cardiac arrest and pregnancy are really important. practicing for OB emergencies with simulation improves outcomes, and a multidisciplinary simulation training should focus on both technical and teamwork skills in order to be most effective. And this involves, of course, not only the physicians, but the nursing, the scrub techs, etc. Because especially if you're going to perform perimortem cesarean delivery, that has to be they have to all be very involved with this process as well. So I want to thank you for your attention and happy to ask any questions. I'm going to stop sharing.
Thank you, Dr. Stone, for this very thorough review of a problem that we don't see often. And it's something about, the pregnant patient that some of us are not very comfortable with, obviously. You said something about, the OB code. Can you describe a little bit more about the OB code team and how you put it together, how we summon, and what are some of the things you do to drill for it?
Yeah, it's really a great question, and again, something I think that Evan mentioned before that we should work on, but it really involves making sure that the right people are on that team, that they're called, right? So super important that we often don't include our neonatal colleagues there. So they really need to be there in the case of a viable fetus, anybody that's over 20 weeks gestation. Sometimes if patients roll in through the ED or and we don't know the gestational age, we have to just sort of estimate that. But getting all the right people in place on the code are really important, making sure that we have the right equipment, because if it's done down in the in the labor floor, we might not have the all the equipment that's needed. So I think it's something that we should develop. As I guess I don't really want to talk too much about the prior case, but it does come up when a code is called, like, oh, is this a neuro code? Oh, is this a code? Like, what kind of code is it? But I don't believe that we have a specific OB code. So I think, and I'll double check on this, but it's something that I think we certainly should work on. For me, the most important things are, this OB code, so we get the right people in place, and we got involved the ED as well, and then simulation. And I'm not sure where where in the critical care world you do your simulation, but certainly we can come up with ways that we can develop simulation for cardiac arrest. Again, they did it recently at West, and we can do that.
We have two resources for simulation. One, the ED simulation group, and second, the anesthesia simulation group. So we sim all the time, and actually Dr. Liebner, Evan, is one of the leads for the simulation. I think it's a very worthwhile thing as we put the various functions of the ICCM together. We have rapid response teams and of course code teams and nocturnal intensivist team, that we should really work together to form an OB code team so that we are always available and prepared.
I think that would be amazing. Yeah.
I'll talk with Dr. Kohli and Dr. Liebner to work with your group to make this happen. Dan Katz is running the code group for the hospital, the CPR group. So we'll make it happen through there. Patrick Marr represents ICCM in the code group. So I think we have a core faculty that can make this happen.
Yeah, perfect. Yeah, I was just going to mention Dan Katz because I know he's really involved with that too.
Yeah. I'll send out actually an email right now so we get it going. Thank you. Dr. Brown, you had.
Yeah, I wanted to ask about age of patients, because more and more women are putting off childbearing till the older age. And is that a contributing factor? And also the epidemic of obesity, and obesity has other additional complications because the blood volume is bigger to start with. and as a consequence, and the lung volume is smaller, the FRC is lower to begin with. So are those people at higher risk, and therefore we can prepare in advance maybe to consider this this as an event?
Yes, it's an excellent point. Yeah, you saw in one of the slides that about 245% increase. I mean, that's huge, increase
Right.
in the incidence of maternal cardiac arrest. And it is thought to be related to all the factors that you mentioned. So people are delaying childbearing, getting pregnant at a later age. So underlying comorbidities like obesity, like diabetes, these all, contribute to that. And the other one I mentioned is that because of the real advances in the treatment of congenital heart disease, patients are living longer to childbearing age with congenital heart disease. So that also contributes to it. So I think identifying those early on as patients who might be at risk, and then having this multidisciplinary team approach. I mean, the incidence is still quite rare. So, if you look at obesity alone, we can't probably target that as much, but should be aware. And then again, those same patients bring more challenges to the resuscitation efforts too. So yeah, it's an excellent point.
Thank you.
Thank you.
Excellent presentation.
Thank you. I hope it wasn't too below your.
Okay.
No, not at all. Not at all. I think it was a good review, because we don't take into consideration every day this, I call the video of events rather than a snapshot. It's when we see the patient as a snapshot. So this sequence of events is very important to understand in order to know what is the best way to handle it. It's not easy.
No, and again, when there's something that's infrequent but catastrophic, it's, you have to sort of always review it and remember, what the changes are, and there's specific changes related to pregnancy, which are quite different.
Right.
Great.
Thank
Any
you.
other questions, anyone? Thank you so much, Dr. Stone, for this discussion. And we really appreciate your time and effort that you put into doing this for us.
Well, thank you so much for inviting me. It's been really interesting, and looking forward to collaborating on some of the things we spoke about.
Absolutely. Great. Sounds good. Thank you very much. Okay. Bye-bye.
Bye-bye.